Thank you everyone for making time to be here, and welcome to our second webinar in a series leading to International Women's Day. Uh, this year's theme speaks to accelerating progress in closing gender gaps. And with that, the title of this webinar is Invest in Women, Accelerate Progress to Gender Parity in Leadership. I'm your moderator, Margaret Munakampe, and I'm Policy and Planning Manager at Women in Global Health Zambia. Gender inequalities in leadership opportunities continue to stall progress toward achieving gender equality, and the UN has stated that it would take about 140 years for women to achieve equal representation in leadership positions within workplaces. A report by Women in Global Health published in March 2023 on the state of women and leadership in global health highlighted what was referred to as the XX paradox, which is that globally, women hold 70% of health worker jobs, over 80% of nursing, over 90% of midwifery roles. They deliver the most unpaid care, domestic work in families and communities, and the majority of health purchasing and usage decisions. Women lead delivery of health to 5 billion people, contributing an estimated $3 trillion annually in global health, half in the form of unpaid work. Yet women hold 25% of leadership roles in health. If leadership roles were allocated proportionately, and if women and men were given equal merit, then approximately 70% of health sector leaders would be women. Yet men hold who are less than 30% of the health workforce, hold 75% of leadership roles. So where have we gone wrong? So to help us understand this, allow me to introduce our panelists today. We have Dr. Cholwe Jacobs, who is the head of Epidemiology and Biostatistics Department at the University of Zambia School of Public Health, and the country director and co-founder of Women in Global Health Zambia chapter. Cholwe has extensive experience working in global and public health in collaboration with government and various local and international agencies, working on gender, sexual and reproductive health, maternal, newborn, child and adolescent health, HIV, AIDS, and non-communicable diseases, where she uses gender and health equity lenses in evaluating programs, both utilization and access to health services. She has studied at the University of Zambia, University of Otago in New Zealand, the University of KwaZulu-Natal in South Africa, Johns Hopkins University in the US, and she's also a Harvard and Vanderbilt University fellow. Cholwe, help us understand more about women in academia navigating leadership spaces. Welcome, Cholwe.
Thank you. Thank you.
Thank you. We also have Dr. Lucy Mazianga Mazawa Liwewe, who is the Health Diplomacy and Public Health Specialist at Zambia National Public Health Institute. Mazianga is a public health officer and researcher with over 20 years experience in public health, including lab diagnostics, particularly virology, epidemiology, strategic communication, risk assessment, surveillance, and outbreak response. She's part of the lead team that established and operationalized the ZNPHI and Africa CDC Southern Africa Regional Collaborating Center, and the Institute's public health bulletin called the Health Press Zambia, where she serves as inaugural editor. She sits on various local and international working groups and participates in international and collaborative research. She is a philanthropist, a subsistence farmer, and enjoys baking, flower, gardening, sports, and keeping fit. She's a mom of 5 and also a grandma of 2 beautiful girls. Mazianga will help us understand gender equality in leadership within Zambia's public health space. Welcome, Mazianga.
Thank you.
Okay, thank you so much. We also have Mr. Kelvin Sikwibele, who is the CEO and founder of Impact Health Measurement, Southern Africa. Over the last 14 years, the social enterprise has expanded from being a foundation to a robust workforce of 89 staff in Zambia. a presence in Eswatini, Lesotho, and South Africa, demonstrating Kelvin's exceptional leadership in managing extensive teams and championing cross-border initiatives to enhance health outcomes and gender equality in leadership and decision-making. Kelvin is a seasoned demographer with a Bachelor of Arts from the University of Zambia and a Master's from Witwatersrand University. He works with gender disaggregated data and has been pivotal in highlighting gender disparities within health initiatives. Kelvin's dedication extends to global dialogues that expedite progress towards equitable health outcomes, including leadership, underscoring the vital role of women in health and the urgent need for gender-balanced leadership. Kelvin is a male ally who will share more on what men can do to advance gender equality. Is it a women's issue? Welcome, Kelvin.
Thank you, Margaret, and thank you to join this esteemed panel. I'm looking forward to very productive discussions. Thank you.
Okay, thank you so much. And finally, we have Rachel Thompson, who is Women in Advisor for Research, Advocacy, and Policy. Rachel has worked with Women in Global Health since 2020, and she has a background in anthropology and public health. Rachel has over a decade of experience across humanitarian, global health, the development sectors, and including several years working on health programs in parts of Africa and Asia. Her previous research projects have looked at family planning, Ebola response, universal health coverage, non-communicable diseases, and healthcare in conflict zones. Since returning to the UK, Rachel has worked as policy advisor at the World Obesity Federation, and with Women in Global Health, Rachel leads research projects and manages work on gender equity in the health workforce. Rachel will share highlights from the report highlighting the XX paradox from Women in Global Health. Welcome, Rachel.
Thank you. It's a pleasure to be here. And yeah, what a stellar panel you've put together. Thank you.
Thank you so much. So without taking more time, we'll just give each of the panelists a few minutes, 5 minutes, to give any opening remarks and just talk about our theme today briefly, and thereafter we'll just dive into the discussion. So I think we can all just take a turn, just following the order that I used when introducing us. So that would be Cholwe, Mazianga, Kelvin, and finally Rachel, who highlight key information from the report. Cholwe, please go ahead. Thanks.
Okay, good afternoon, good morning again, and good evening, wherever you are joining us. Thank you, Dr. Margaret, for the introduction. It always feels good to listen to being introduced, because most times we fail to introduce ourselves sufficiently. And thank you for the opportunity to just highlight a few things, even as we open up this discussion. An important discussion, particularly around, as you indicated, Dr. Margaret, that I'll be focusing on leadership within the academic institutions. For me, this is a discussion that is very important. Important not because I'm within the field, but important because this kind of discussion, most times ignored and left out, is very key because it opens up conversations beyond just our sexuality and beyond just a biomedical understanding of who women are. It opens discussions about realities within academic institutions. For most of you that are within academic institutions, you will agree with me that while currently we have almost equal representation in achievements and opportunities for academic positions, such as faculty and researchers, I want to give an instance where we have existing evidence that shows that both in the Global South and Global North, there's almost an equal achievement in attainment for master's programs, for PhD programs. And as this is an important qualification, as you may know, for academic positions. So this is gratifying. This is a huge progress. However, statistics also show that gender disparities still exist particularly in high academic leadership positions. And this is despite an equal representation across disciplines at area career stages. For instance, in a quick one, we have evidence that shows that in 2018 in the Netherlands, 44% of PhDs were awarded to women, and yet only 22% of these women had tenured faculty positions or strategic positions that position them into leadership. We see similar patterns within our own academic institutions in the Global South, where a number of women are being employed. We see a lot of emerging scientists, young career women or faculty, but only a fraction of them hold tenured or strategic positions. So for me, Dr. Margaret, this discussion at a time as such is very key. It's crucial because it opens conversations around realities and lived experiences of women within academic institutions. And allow me to state that while these patterns, disparities and inequalities with women, few women holding leadership positions, of course, a number of them are thriving and are pursuing, and we see a number of them for some institutions that are holding these leadership positions. But we need to acknowledge that even if this is a case, there are systemic barriers that deter most women into strategic leadership positions. If I may, maybe I should pause now. I'm very mindful of the 5 minutes. Let's see when we get into the questions and answers. Thank you.
Okay. Thank you so much, Chogwe. We'll also now hear from Mazianga. Please go ahead.
Thank you very much for the opportunity, Dr. Margaret. Indeed, it's exciting for me to be on this platform to discuss issues surrounding, gender disparities in terms of leadership. I will be speaking more in the area of public health because I sit in that space and I have firsthand, what's the word? I have firsthand experience, that's the word, firsthand experience in the public health sector. So I was looking at the theme for this year and it says, invest in women, accelerate progress. And, I just thought through it and I said, it's exciting to hear all these themes. And there's a lot of talk around, gender equity, gender equality. There are all these policies that are in place to ensure that. And yet, and more so in the public health space, that's not what is happening. The numbers are not speaking to these policies and talks that are, all over the globe. And, when you look at the theme, it seems very easily achievable, with all this vigor and excitement around this topic. But in effect, it's not really as it seems. And situations that can be leveraged on to address, these barriers effectively and, of course, timely. We do know that public health policies and initiatives play a crucial role in promoting women's leadership in the public health sector. And so we need to push and leverage on these existing policies or strengthen and implement these policies, because it's through these that we're able to address, the systematic barriers that Dr. Jole talked about, creating, supportive environments and fostering opportunities for women to achieve, and thrive in the, leadership roles. I think one of the most important things to note, even as we talked about what I'll discuss, is that even on the global fora, we recognize that, coordination, collaboration, and partnerships are key to and significant to, supporting the implementation of gender equality policies, in the public health leadership across the different countries, recognizing the dynamic situations each country has, and the ever-changing political scenario, technical scenario, and so on and so forth. And I think, in my opinion, that we need to facilitate a lot of knowledge sharing, learning from other people's experiences, continued capacity building, advocacy and awareness, and of course, the most important thing, not the only important thing, but also an important agenda, resource mobilization. And when we're talking about resources, we're talking about human resource as well as financial resource. And I think Dr. Joel talked about, the academics setup and how, there are all these policies around scholarships and so on and so forth, but are they really effected in these places? So I look forward to this conversation that we have today as we delve into the details of, what challenges and opportunities there are in this leadership space in the public health security sector. Thank you so much, Dr. Margaret.
Okay, thank you so much for those words. And I can see already some, we are converging on understanding that we've made some strides, but the disparities still exist, and that we still need to do something about these disparities. I think we can move on now to Kelvin and hear more from what he has to share with us. Kelvin, please go ahead.
Thank you, Margaret, and thank you to Cholo and Mazianga for setting the tone. So good afternoon and morning, perhaps, for those who are joining us out of Zambia, esteemed colleagues, panelists, and participants. My name is Kelvin Sikwibele, co-founder and CEO for the Institute of Health Measurement. We are an organization that's working in the area of health informatics here in Zambia, but we also have offices in Eswatini, Lesotho, and South Africa. With a passion deeply rooted in health informatics and commitment to gender equity, I've dedicated over 24 years of my career to leading initiatives that not only improve health outcomes, but also champion the cause of women in leadership within the health sector. Having been invited to speak, this is really a special honor for me, as this is a subject that really touches me. When I heard Cholo speak about the conundrum that we found ourselves in as a country, and the work that needs to be done from a global perspective, but drawn down to the Zambian context, I'm really thrilled to bring in the perspective of technology in this discussion. I heard Mazianga speak about the fact that she's coming from a public health position. Drawing on my background as a demographer, I have focused on leveraging gender disaggregated data to inform policies and interventions that aim to bridge gender gaps. IHM, specifically in Zambia, is working closely with the Ministry of Health and other implementing partners. We have the responsibility of rolling out Smart Care, an electronic health record, in government-owned facilities as well as some private-owned facilities. And so from a technology perspective, what I'd like to draw here is the ability to collect data that we can use. What is special about Smart Care is that for the first time, we're beginning to reap the benefits of a system that's being rolled out at the national level to give us insights from routine data that is going to be near real time. Smart Care IHM has worked to improve smart care to the extent that the current version that is now being considered has a data latency basically of 24 hours. Our goal is to get it into all health facilities by September 2025. But I can tell you now to say by September this year, smart care will be in half the facilities, which is about 1,600 facilities. What that means is, colleagues, essentially, once we are done with the rollout, when you wake up the following day, you will have data from these facilities that then can help you understand what's happening. But also IHM has worked very hard to unravel the whole space of data management and making it accessible and readily available and usable through the development of a data warehouse. What we've done is we've pulled all facility-based systems, but as well as administrative systems such as the Human Resource Information System, as well as the Financial Information System in the Ministry of Health, into a central place then that allows people to have access to this data. What is interesting and what we've been observing as we work in this is the dynamics that then you can bring to the fore when it comes to data. One of the things I've noticed, just to wrap up my 5 minutes, one of the things I've noticed is that we've struggled really to bring data to the fore to tell the story of some of the challenges we're having. When I heard some of the percentages that Cholo was highlighting, I couldn't help but imagine what we would be able to talk about if we brought more of this health data to the fore. So for example, with the Human Resource Information System, we will have a clear sense of how many women are in what roles and where they're deployed in this country, and how long they've been on the system. So there's just so much analysis that we can bring to the table. So today I'm here to share insights and engage in a dialogue on how we can collectively harness technology, challenge stereotypes, and foster collaborations that advance gender equality, particularly in leadership roles within health. I look forward to a productive discussion and the exchange of innovative ideas that will drive us closer to achieving gender parity. Thank you.
Wow, thank you so much, Kelvin. And as a researcher myself, I feel really excited, you know, at just having a lot of having accessible and available routine data at the public health level. I think that's really, really exciting. Thank you so much for that. And we look forward to hearing more on that later. Finally, I'll call on Rachel to just share a little bit about this XX paradox that we've already hinted on. So Rachel, please take it up. Thanks.
Thank you. So I may be a few more minutes than 5, but I hope this will be interesting and informative. Let me see, how do I actually move it on the, oh, sorry, yeah, just slow. So next, yeah, lost my, it might be in the wrong order, never mind. So I'm going to be talking about some of the evidence that Women in Global Health has generated globally in the name of making the case for women's leadership in health. So we've had the headline figure already, and this idea that Margaret described of the perverse situation where the majority of health workers are women, but the majority of leaders are not. And we've called this a default male bias in health. And this can also be found in, so the idea is that the default health leader is a male, but also, for example, in medical PPE, it is designed for men, despite the fact that the default health worker is a woman. So this concept, the XX paradox, is not only in leadership, but actually extends in other areas of the health system. Also in terms of policies, if the default health worker is a woman, she may well end up having children and needing maternity leave, etc., support and safe spaces for breastfeeding when she returns, and yet those are still not the norm, these kind of things. So this is the starting point. And again, this idea of why we need to make the case for women's leadership and how we make the case. Women in Global Health talks about a triple dividend. And we have 3 components of this. In terms of health, we believe that when women are enabled to enter leadership, their perspective strengthens health systems and delivery. And actually, it's not only about improving women's health, it's about improving health for all. So that's one of the arguments that we make strongly, that actually sometimes we see a focus that women in leadership will benefit women's health, will, for example, increase investment in some of the neglected conditions that women's cancers, etc., which is true, but women's leadership will also improve everyone's health in universal health coverage. So we also have a gender dividend, and it will also benefit families when women have, saying my connection's insecure, sorry, and women will have, young women will have role models, etc. And also the economic and social dividend. So more women in leadership will lead to a stronger, to decreasing the gender pay gap, potentially, and like we've heard at the beginning, the amount of GDP generated by women in health is huge, but not being fully harnessed yet. So about the report that we did, Margaret alluded to, we did research with chapters in 3 countries, Nigeria, India, and Kenya. This research was done in 2022, and we are planning many more country case studies in the future, funding dependent. But yeah, these 3 countries were selected initially. And we use the ecological model, which some of you may have seen before, to structure our research. So this is the model that looks at women and women's leadership in the context of individual, but also interpersonal, community, institutional, and public policy factors. So we can't just look at the individual factors why a woman may not be able to achieve leadership. We need to look at the whole picture. So what did we find? So the headline finding we've discussed, that women, and really what we looked at was the trends. So in 2018, it was only 25% of leadership roles in global health. 5 years later, still no progress, which was a little bit disappointing to say the least. However, we did during the qualitative research that we did, we found a lot of examples how women are leading health and shaping and sometimes redefining leadership in ways that may not be fully recognized. They may be less hierarchical. Women may tend to be more inclusive, empathetic leaders. And we've got some really lovely data on what leadership means to women working at all levels of the health system. But we also found that some groups of women are most excluded from health leadership. And in low-income countries, women community health workers have pretty much no access to even career progression or leadership. And this is a priority for women in global health now. And we will be having a new, spinning out of this report, we'll be having a follow-up one on women community health workers and leadership. So watch out for that. We found, we looked at these 3 contexts, but we know we have insights from the whole movement that despite the different contexts and differences in culture, there are remarkable differences, remarkable similarities, sorry, across respondents and across the anecdotal evidence that we gather. So the big ones, which I don't think will be much of a surprise, but just to go over, we've got some nice quotes here. Gender norms and roles limit women's participation potentially to enter work in some cultures, but also in terms of in accessing leadership. So yeah, of course, we have this idea that women's job is in the household, and in some countries, women are still struggling to enter the workforce. But then those women that can enter the workforce still face gender norms that mean they are limited and they are not respected as they should be. The motherhood penalty comes out very strongly across all the countries and is a universal issue that has not been fully addressed, that when you do take time off, or even that your boss may think you're going to take time off, it can have detrimental impacts. Also, when you come back to work, we heard about women being punished even because they had taken this holiday of going to look after their baby. Stereotypes really important, and this notion that women have to work twice as hard as men to achieve the same things, and even when they do achieve success, they have to they're held to higher standards, and it's a constant fight. So what needs to happen? Well, global commitments are there. And in national policy too, we do find some good language, some good ambitions, but implementation of policies is poor, whether that's to do with maternity leave or prevention of sexual harassment. It's not being operationalized in health systems, and women are suffering. And we have, this is our cartoon that we've had for a few years now, where you can see the pipeline of global health is actually full of women all around the world, but there's a blockage, and they're not, women, especially women from low-income countries, are not entering global health leadership as they should be. So what can we do about this? Enabling diverse women to lead. It's a fairly general one, but what we're talking about here is created tailored opportunities. So this is using an intersectional lens, because we know that not everyone can access opportunities equally, and we need to make sure that those considerations are factored, whether that's a global program or a national program. And like I was saying, with women community health workers, how do we harness their potential to be community health leaders and to improve health for all? The big recommendation that came out as well was also around the need to fast track, to be super intentional. This problem is, time alone is not going to solve this problem. We've waited long enough. We need all women shortlists. We need quotas. We need to ensure that women are at the table for the top jobs. And what we've also found is that for women, merit is not necessarily enough. Despite that's what we've generally grown up to believe, that if we work hard and we can demonstrate all the criteria, we'll get the job. But in reality, especially when roles that are political, that's not the case. And women need champions, as men often have more commonly. And women need women champions, but also male champions. So it's great to see an ally on this webinar. Increased in visibility is also important. So Women in Global Health platform tries to do its bit there and just make sure that those names are on the list when they need to be. Yes, mobilizing men, this idea of leading out, stepping up as allies. It's not just enough to be a supporter of women's rights, we need to see action. And we've got this term male bonus syndrome, which is where men benefit by the status quo. So we need to really make sure that they are stepping up and going above and beyond. I think that includes championing paternity leave and other policies. So that's and that's similar in the default man bias I've been talking about, and we need to prioritize implementation of policy.
Jake.
Hello.
To realize.
Could you
the final
mute
one.
our mics? Could you please mute our mics? Thank you. Please go ahead, Rachel.
The final one is around supporting women's movements, like Women in Global Health. And this one is especially targeted at donors because we've seen a chronic underfunding of women's movements. So we're always looking for, to strengthen the case for women's movements, which are not just for women, are for allies too, of course. And this idea of collective action that I feel very proud Women in Global Health is really embodying. So I think I'll stop there, and I can pick up on many of those points in the discussion. Oh, sorry, final recommendation on more research, of course. Thank you.
Okay. Thank you so much, Rachel, for that. And that's very insightful. And I'm very interested in the recommendations, particularly fast-tracking actions, because in our opening, we did say the UN thought it would take 140 years for us to achieve gender equality in leadership. And so fast-tracking and intentional action could actually help us realize this sooner than 140 years when most of us here won't even be there. Okay. So we'll just dive right into it, and I'll start with a question for Cholwe, and just trying to understand this academic space and trying to understand the barriers within academic spaces, it was interesting to understand that we have seen some, strides being made in academia. Then where are we going wrong? Why aren't we reaching the top leadership positions? And so how are women in academia currently overcoming systemic barriers to access? I feel we need to talk about this a lot more so that we may actually reach the summit, reach the apex, and not just end up somewhere in an administrative role. How can women overcome these barriers? I know it's a tough one, but
Okay.
please try.
Thank you, Dr. Margaret. Good question indeed. Before I dive into the response, let me start by stating this. This one I need to. Academic career life can be so challenging for women, particularly given the deep-seated structural and systemic biases that most times will favor those who can travel, those who can conduct research, and those that can sit back in the office and spend long working hours to be able to publish. Performance in academic entails, particularly within universities, so the definition for good performance, you should be able to apply for grants and lead research, but also you must be good at publishing. So for those with parental and caring responsibilities, these challenges can present major barriers indeed. For instance, for too long, maternity leave can create gaps in women's research trajectories, which can be viewed as a failure to perform consistently over time. For a junior faculty who comes within the space, for most of them, within this given time, they have quite a number of responsibilities, which include maternity, and the derailment, if I may say so, the detour that they incur may lead to failure to perform consistently, because they will not be able to publish, they will not be able to participate actively in research. But also, whether women have parental or caring roles or not, female academics often get channeled. And I heard you talk about this, Dr. Margaret, that we get channeled into teaching-oriented administrative posts that have traditionally and actually incorrectly been accorded less value within promotion structures. So the promotion structure for academic institutions most times will not take into account administrative roles. And yet, these keep most academic departments functioning. So this then means that when women publish less because of additional responsibilities, they have less time for external and international networking because most times they cannot travel. This means that they would also fail to apply for large grants. So this is depressing, really. And there's also evidence that even within the teaching responsibilities, women are often evaluated more negatively than their male counterparts. Now, coming back to your question, Doc, how have I navigated in all this? Maybe I haven't. I'm struggling, truth be told. Balancing between roles and caring roles, family roles, and academic roles is not easy. So what that means is that I need to put in a lot more effort. There's a lot more effort that is needed for me to balance. And secondly, I think when I talk about how we are navigating, I must say that it's really a big challenge. Why? It takes determination and resilience. And for me, I think for those that we've seen go up, this has really worked. The thinking, never giving up really works for those. And we've seen those that have strived and gone up, really that there's been a lot of push. Talking about navigation again, how have we navigated? I think capacity building. And I must take this in academic, and these are my perceptions. It may not be so for others. I think what helps most female academicians is the capacity building, looking out for opportunities to develop and develop and develop, and we keep developing to prove that we can attain those positions and that we can do it. Such that for most of the time, for a female, they're trying to make efforts to develop themselves to be given some of the specific roles. But also, I think what helps most academicians that have navigated their ways is willingness to learn from others. And I want to state here that this has really reflecting on my own experience and who I've become as a scholar. I must say that being a female researcher and academician, especially as a woman, as I've indicated, is not an easy road. But learning and leaving room to be mentored is key. So being mentored, you work with others. There's a saying that, so taking up deliberate moves and also opening yourself to mentorship makes it a bit more easier. And there's a saying that goes, alone, you can run fast, right? But together we can go far. So within academic institutions, for thriving purposes, learning to work within a community of mentors and peers is so critical. It is vital to start becoming a mentor as well, and to look around for supportive peers from the get-go, from the beginning, as one in academic environment cannot sustain themselves in the career of academia without a community of people that can stand with them in solidarity. So when I talk about mentorship, what that does also is that it helps you to build teams for you to thrive, because alone, it's difficult, it's challenging. So the aspect of team building teams, looking out for mentees, and looking out for peers that you can work with so that you have a supportive environment that will encourage representation for women. It is also important to note that as females, we need to be role models, even in the academic space. We need to be role models in the positions and show that it is possible, show the young growing faculty that it is possible for women to undertake these jobs. It is important that women make strategic decisions. And so they need to navigate and find ways that we can survive even within the challenging systemic barriers. Allow me to quickly sum it up by saying, to make sure that this is a reality and we become role models, I think we need to ensure that the environments that we are in are supportive. Working to be more inclusive and supportive begins with creating spaces for conversations, like we are saying. This is a starting point. These discussions are healthy because they help us open our eyes, and also they help us realize some of the barriers that exist. And this requires being intentional, by the way, being intentional about these discussions, but also ensuring that we have evidence to justify our advocacy. Evidence that will help others to listen and to support topics such as these that we have. And I also think that strategic leadership roles for these ones, I think there's need to make sure that if these are attainable among women, we need to make sure that we have networks like Women in Global Health, CSOs, that will be voices of the voiceless, because life out there can be so challenging that sometimes people may think, does it matter to be in a leadership role? So may I end there, Doc, and maybe we can talk about some of the other aspects that we can talk about. So these are some of the ways that I thought I could mention how academicians, female academicians, have managed to navigate through these challenging systemic environments. Thank you.
Okay, thank you for sharing those insights. And to be honest, I wasn't very interested in coming here to talk about barriers, but to talk about solutions, because we've talked about barriers a lot, and it's interesting to hear us talking about all these approaches, building teams, being intentional, role modeling, creating supportive environments, evidence networking, and I know these are not things that are very easy to do considering the status quo, but one or two actions in the right direction, I think it can really go a long way. So thank you so much, Dr. Jacobs, for sharing those insights. And I'm going to try to move slightly into this broader public health space. And Mazianga, are these approaches that would help at a system level, at the national level? How can we overcome the barriers at that level? Mazianga, are you here?
Yes, I am. Thank you.
Okay, sorry. I think we got a small disruption there. But
Or
we were just hearing how we can overcome barriers within the academic public health space. But how can we overcome these similar gender equality in leadership barriers, the national level within the public health sector space? Please take it up.
Thank you so much, Dr. Margaret, for that important question. And I'm happy that even while we talk about barriers, we want to emphasize on the issue of what can we do? What are the opportunities that are there to, mitigate the situation at hand? And I think that first of all, it would be good for me to give a bit of a background on some of the opportunities and strategies that are existing within our public health space. Also to note that while there are so many of these, achieving that gender parity in the country requires a significant acceleration of policies that promote specifically and sustain women's economic empowerment. And I think it starts from there. And when we look at that, things like promoting gender inclusiveness in leadership, and the policies are there, but we need to implement them. We need to ensure that within the public health sector, we include, setting diversity targets, conducting regular diversity and inclusion trainings, as well as creating and supporting work environments and that value, the diverse perspectives. It's also important that, we continue to provide leadership development opportunities. And I like the fact that in the Women in Global Health Zambia, there's this drive to ensure that, there are all these trainings to capacitate the women so that it's not like it's a favor, it's because we are capable and available and are qualified to participate at that leadership role. And so we need to be able to invest in these development programs through mentorships, training, and so on and so forth, to support women to advance their capabilities in the public health space. And like I said earlier on, we talk about things around mentorship, training, coaching, networking, opportunities which Women in Global Health supports, and skills workshops, and so on and so forth. Of course, apart from systematic, there are also structural barriers, and therefore we need to address these structural barriers that keep impeding on women's career advancements. So for example, when we're talking about structural, and I think I did hear Dr. Chore refer to some of these inequitable hiring and promotion, practices. You hear, oh no, women are encouraged to apply for this position, and yet, in actual fact, you don't even have the position given to the women, even when they're in that space. You know, we need to be able to encourage, you know, the establishment of I know they say what you don't know should not impede you from progressing, but we know that sometimes there isn't adequate awareness, and so it's important that we continue to raise this awareness, to speak about it more often, and you know, challenge some of the things around the stereotypes. You know, the importance of gender equality leadership and the challenges of stereotypes. You know, usually hinder women's progress, and so we need to promote positive, you know, representation of women leaders in the public health space, and celebrate these achievements. And I get excited every time when women on global health, when somebody achieves something and they put it out there. And you know, we need to celebrate this and celebrate it widely, not just in our personal space as women, but beyond that, so that, you know, it is known how progressive, you know, the women we have are. And I like the aspect of research and looking at information, evidence-based decisions needs to be pushed. That agenda is important. And so we need to, you know, collect, analyze our data and speak into, you know, what is really happening in terms of gender representation, rather than just, you know, assuming that this is what it is, because this is what it is in Zimbabwe, this is what it is in Zambia. We need to get specific information, evidence in our context, and then advise or influence policy regarding these you know, gender disparities that we keep talking about. So in summary, you know,
Okay, thank you so much. Just want to confirm if I'm audible.
You are.
Okay, thank you so much. Thank you, thank you. Thank you so much for those insights, Mazianga. And again, I'm seeing this the value of celebrating wins, the value of taking stock of successes, the value of leadership development opportunities, diversity targets, actually, because we're seeing here the importance of, you know, evidence and assessing how we're doing so that we can see where we need to be. And so just highlighting this theme of evidence, I think Cholo mentioned this as well. How are we doing in terms of data, and you know, how are we doing when we come into this space where we need to generate evidence to actually back up our for us to actually walk the talk and have, you know, a bedrock for us to base our discussions on. So moving to you, Kelvin, I'm going to basically throw a two-pronged question at you, seeing as also we are running out of time. But how can technology be leveraged in addressing specific challenges faced by women in accessing leadership positions? And also, how do we actively challenge disruptive, you know, harmful stereotypes and norms? This is something that we saw coming out prominent in the report that Rachel shared. So as a male ally, how do we challenge these disruptive norms from your experience? How do you see us achieving this? Yeah, please take it up.
Thank you. Thank you. I'm not so sure about the strength of my connectivity, so I won't turn on my video, but I believe people have had a chance to see me. Maybe at the end I'll do that. But straight into your question, you see, one of the reasons why we set out to establish IHM was just the lack of data in the health sector in this side of the world. And where it was available, it just basically wasn't in usable formats for two purposes. One, for driving dynamic program implementation. In other words, as we implement programs, do we have the data that would allow us to make changes? And then two, data that would allow us to look back and therefore change policies in response to what that data is telling us. So also just quickly, just as a litmus test, one of the things you can do, even for colleagues who are online, is just to go and visit the Gender Division's website. There's a component on that website that is supposed to give you data on gender disaggregated statistics in Zambia. That page is still under development. It's been in development for a while. They've got reports. The last report was in 2019. I'm not saying this to call them out. I'm using this example to show the problem that we have with data this side of the world. And so then as you ask me those two questions to say, how can technology therefore come in to do these things? Of course, the first one is how technology has then made data collection much, much easier. I like giving this example for people to appreciate how technology has really improved. For the older colleagues on the call, you remember there were shops like NIEC sometime back in Zambia, the department stores. And the cashiers used to use manual the manual machines to basically capture your groceries. You know, they were like typewriters where they would punch in the numbers, and it was really horrific. And if you remember the queues that we used to have those days, but if you fast forward to today, when you walk into ShopRite or Pick and Pay, they're using barcodes basically. Nobody's calculating those numbers to come up with the receipt. That's the power of technology, and that's what we are doing with systems like SmartCare. We are basically harnessing the best of what we've seen out there and bringing it to basically fulfill three things. One, to ensure that clinical workflows are supported with technology. Two, to reduce the burden of data collection. And then three, of course, to show that by bringing technology, we actually improve health outcomes. And so for SmartCare, one of the things I'm really proud to share with you today is that we've brought in for maternal health services a digital pathograph that then will allow for accurate recording of women's experiences as they go through labor and delivery. We've also expanded the ANC or the MCH module to cover the three phases, prenatal, maternity, and postnatal experiences. And so we want to ensure that we're able to collect that data that then will allow us to begin to have the kinds of insights that were not possible previously. So with technology, we now will have the basis upon which colleagues like Mazianga in ZNPHI will actually begin to bring the magnifying glass of gender onto this data to show us what is happening. And then another thing that I think technology does is the way in which now data is being used. Today, people say, if you want to win in any sector, it's on data that you're going to win. And so if we have these capabilities of these systems that are going to be rolled out at this level, which is totally unprecedented for this side of the world, and then we're going to have this amount of data, can we then bring the expertise of analysis to the table so that then we can be producing reports, statistical reports, analytical reports, insightful reports on what is happening in the space. The beauty about the technology that we're bringing to the table is that it will combine not just routine data, but as well as administrative data in terms of the human resource information system, the finance management information system. So that's one way in which then we can be able to tell the stories. Another thing I did in preparation for this webinar was to go and visit the Nursing and Midwifery Council to see what kind of data they have there. A similar thing with them on their website. There's a section where they ideally were supposed to find data, but there isn't. And again, I'm not calling them out. I'm highlighting the challenges we have in gathering, analyzing, processing, and putting out the information that can paint a clear story of some of these challenges that we have, so that then the solutions that you are asking for, Margaret, can really then be granular and work for our country. So one of the ways we can do this over and above just having data is take advantage of some of the things that Chole mentioned to a large extent. The platforms around mentorship and networking. So we live in an era where we are no longer held back by geography, but now we're actually exposed by technology in terms of going online. So I'm talking about digital platforms. So GDH itself, I was really impressed with what GDH wants to do. So as a network, I would invite you to say, bring in a digital element to the way then you begin to connect with women in the health space. When we roll out Smart Care, one of the things that we noticed was that provinces and districts were establishing WhatsApp groups to help each other in navigating the way they use Smart Care and giving each other tips. Social media can be used in this regard as a digital platform to create these mentorship groups, to create these networking groups within the health sector that can then advocate. So for me, those are the two immediate examples that come in. And then to your other question around how then male allies can challenge these harmful gender stereotypes. Two things, because time is not with us really, that sat with me when I was invited to speak at this webinar. Two things really. One is the unconscious bias that us as men hold. And then secondly, it is just this whole thing around privilege. I think as a social entrepreneur on my side, and when I look at what I've done in IHM, we've got to walk the talk. Just recently, we wrapped up, from a personal example, we recently wrapped up, what do you call this thing? These young people that come to work with you so that they can gain skills.
Internships.
Internship, thank you. The word escaped me. So we recently wrapped up our internship for 2024. We've onboarded 12 young IT people. And when I was called in to meet them, I was so disappointed to find there was only one young female. And when I asked, my colleague in HR said, Kelvin, we've tried, there's nothing. I said, no, if you tried, we would have had half. It means we haven't done enough and we need to go back to the drawing board. So as Cholo said, or is it Mazanga who was saying, you see these adverts that say women are particularly encouraged to apply. So I put my foot down and said, no, I need to see minimum half the positions that we've had here. Because you can imagine out of 12, only one young person has come in. You can imagine how much we've already denied for those who have studied. I know many young people who are IT savvy, female young people, that would have come onto this process. But I'm questioning myself, what did I not do together with my colleagues to change this? And that's where the unconscious bias comes in, because you want to start saying, no, but we've tried. No, but they did not respond. Until you make that deliberate effort in terms of quotas, until you make that deliberate effort in operationalizing policy is there. We have to operationalize it. And so it's for colleagues like me being comfortable to step in, and not comfortable, sorry, recognizing those biases that we have and forcing ourselves to say we have to go back. The thing about privilege is that you don't feel it until you're on the other side. That's when you begin to realize, oh my God, I didn't understand what others were going through. This requires us as men to be comfortable, to step aside. There's this whole concept of being an active bystander, one who watches from the sides, actively challenging those stereotypes, so that then you can ensure that this new thinking then is brought onto the table. So just by way of wrapping up, when it comes to how we should be smashing these gender stereotypes, these harmful stereotypes. As a demographer, I always argue to my friends to say, with demography, we've always shown to say the sex ratio always favors females, not for any other funny reason, but because biologically, if a population is going to replace itself, it needs more females. What this means is that just generally, any family you might walk into, you always find a female. And so it makes you kind of stop and wonder to say, if there's this reality, what is it then that makes us uncomfortable with bringing women into spaces of leadership, of authority, of decision-making, just from a numbers perspective, before we even get into all these arguments, but just a numbers perspective? And so for me, it's these two issues, this unconscious bias and this issue of privilege that we need to recognize. Until you go and sit with somebody who hasn't eaten 3 meals and live their lives, you will know the challenges that they're going through and you will be humbled. And until us men do that, we will not appreciate this. And this is my challenge to fellow men. Thank you.
Thank you so much for that, Kelvin. And to be honest, I'm thinking here, like, have I even done a great job as a woman myself? Because I feel that's the type of action we need to take, whoever we are, to just be more intentional and, you know, to drive this change ourselves and to check where the problem is each time we're trying to undertake these activities. Thank you so much for sharing those insights. I think that was a very powerful contribution to this discussion. And as we try to wind down this discussion, Rachel, thank you so much for highlighting those findings in that report. And I can already see that a lot of those recommendations have been touched by Cholwe, by Mazianga, and the value of evidence, the value of being intentional, the value also we heard from Kelvin of to give people space, But what additional steps do you think we can take to implement the recommendations, first of all, that you mentioned, and also the ones that have been discussed in this meeting? What do we do with this evidence we've collected? How can we implement these recommendations in our various spaces? Please take it up, Rachel.
Yeah, it's a kind of billion-dollar question. And I think I'll answer by coming back to the ecological model that I showed, because what we're talking about is systemic change. So I think there's many answers, and it's been fantastic to hear Kelvin talking and the others reflecting on the individual things we can do, on the things within organizations, but we also need governments, of course, to implement policies, and that's why we need a strong civil society and Women in Global Health to hold our leaders to account, men and women, that have committed in the bigger picture to sustainable development goals, to human rights frameworks, etc. So I think in terms of additional steps, it's a hard one. I think it's doing the same, continuing persistence. We know what needs to be done. We need to walk the talk as individuals in our workplaces. We need to keep intersectional lens as well. And like Kelvin was saying, always be self-aware and question our position and what more we can do, and not take anything for granted. So I think that's probably the final message I would leave with, because we know, certainly in Europe, where I'm from, in America, there is a horrible backsliding of women's rights. Things that we thought were settled are being eroded. And also in terms of women's leadership during the pandemic, we saw how women were marginalized at global level, also at national level and task force, and we cannot assume that things will continue to progress. So I think it's really the additional steps are just being more, just being more active and being more persistent and fighting, really, because it is a continued fight. Next week, I'm going to the Commission on the Status of Women at the UN in New York. And I think I'll be hearing there a lot about the need, of course, to work together, collective action, but also, that we cannot take anything for granted. And if you're thinking about doing something, don't delay. And especially in terms of holding leaders and governments to account, use the powers that you have, use your votes. In the UK, we have this system of members of parliament that we can lobby. Use the channels that you have, because don't assume that it will just that things will just improve, which is a little bit depressing, but also hopefully a kind of call for action.
Wow, thank you so much for that, Rachel. And I think it's a good way to bring this discussion to a close, because we have said something has been done, but everybody does agree we need to do more. And also looking at some of the comments in the chat here, where a lot of us are talking about how, we women need to do more in lifting other women up, bringing them into these spaces. And I think that's all part of accelerating progress, because now we can see that there are women, a few or more in some instances, who are at the top, and they can actually do more to create these spaces. So unfortunately, we've run out of time. I think it would have been great to talk a little more about this. It was a really interesting discussion, and we're just at the top of the hour now. And just as a way to end this session, I'd just like to highlight 5 key areas. And these areas have been highlighted by UN Women this year, 2024. And really, investing in women is a human rights issue, because we need to ensure equal opportunities for women to ascend to leadership positions. Okay, and so we need to address gender discrimination in recruitment, in promotion, and in investment in women's leadership development programs. And we have heard this in our discussion today. We also need to talk about poverty, because it does really hamper a lot of progress for women, attaining these leadership positions. It will definitely ensure more access to education, to healthcare, and to economic opportunities. We need to implement gender-responsive financing, and also shifting to green economy and care societies, where we recognize and value women's unpaid care work. And finally, we need to support feminist change makers, because what more can we say about that? We have, it will help us create platforms to advocate for gender responsive policies, and to also change these patriarchal norms that we keep talking about, that can also drive systemic change within the health sector. So I hope we've had a great time, and thank you so much for staying through up to the end of this discussion. And I'd like to just wish everybody a happy Women's Day, and I hope you get up to a lot of work tomorrow in advancing this theme. Thank you so much, everybody. Happy Women's Day. Thank you, thank you, thank you.
Thank you.